title holders. So they're our beacons out into the hospital and health space who toil so diligently for us in an honorary capacity in the pursuit of our clinical research and clinical education mission. So this is a big day for the Faculty of Medicine and Biomedical Sciences. It's our first public outing since the restructure at the beginning of the year, when we brought together three large schools, population health, biomedical sciences, and the ever-dominant medicine, with 5 cutting-edge powerhouse research institutes and university-level research centres. I won't labour the advertisement of the political broadcast, because on each of your seats you'll have a brochure extolling our strengths and our scale. It's a pretty big day for the university as well, as the research rankings were announced today. And if you use dollars, research grant income as an index of activity, the University of Queensland now does more research than any other university in Australia. 2011, we were third. 2012, we were second. And 2013, for the first time, we're number 1 in the country. So that's great. How does it happen? Well, there are many reasons, but in part, it's because the university applies cutting-edge technologies to problems of medicine. And that's where tonight's topic of clinical genomics comes in. Genomics is big science, it's big data, and it's going to have a big impact on clinical medicine. So the topic we have for you is clinical genome sequencing and its impact on medicine across the lifespan. We've put together a smorgasbord of talent, both local and international, to take us through this topic. The latter we capitalise upon the meeting just over the river here, the International Society of Prenatal Diagnosis, that we worked hard to bring into Brisbane. The meetings were organised by my colleague in the UQCCR, Professor David Price. So it's probably a testimony to the impact and relevance that clinical genomics is going to have on the health of all Queenslanders, that we've been able to gain as long as this diary of medicine and health. Mr. Springborg, Mr. Lawrence, we welcome you to the stage to give us your introductory remarks.
Thank you very much, Nick, and to the other very distinguished guests who are here tonight, ladies and gentlemen. Firstly, thank you very much for the invitation, and unfortunately I have to leave around about 6:30. I had another commitment to launch something else this evening, but this invitation came in and I was very, very keen to be able to come along tonight and to share some time with you before I went to the other commitment, because I do believe that what you are discussing here is so vitally important to the future of medicine and also clinical practice, not only in our state, our nation and our world, that I want to come along tonight and to actually share some thoughts with you. I think that if you go back some 30 or 40 years, we would have really struggled to even understand or comprehend the basics of where we have arrived today with regards to genomics and its application. I remember a number of years ago when I was the Shadow Minister for Science in Queensland, and I was attending a biotechnology conference in Toronto. And on the way, I stopped over in San Diego to go and have a look at a facility that at that stage was pursuing the mapping of the human genome. And it was a remarkable discussion because they were talking about the fact that it was only a few years away and it was going to cost as little as $1 billion or $2 billion to be able to do it. Fast forward some 10 years or so down the track, and here we are with the simple reality of where we can do that now for $5,000 or less, and it's actually going to be heading to even less than $1,000, and in the future probably down to a few hundred or a few tens of dollars. So that's been the remarkable pace of progress in this particular area. That's not to say that the theory around it and genetics is something which is new to medicine, of course, and clinical practice, but I think it just goes to show the fast pace where we've actually moved in this particular area. It of course throws up a whole range of issues that we need to consider as we apply it practically to clinical applications and also patient benefit in this state. And I do understand that during the course of this evening's discussion, and unfortunately I won't be able to be here for this, that you'll be looking at a whole range of issues with regards to its application with reproductive technology and also the clinical benefit that comes from that as well. And in many ways, I don't think the community is actually caught up with this. I mean, and probably many of us, myself included, are only just starting to really understand where this may end up. I think out there in the community, people are pretty excited that there's something amazing happening, that they're also excited that it provides them with an opportunity to be able to determine and influence a whole range of things that they would not have been able to even dream of a few years ago, but they're not quite sure where that may be. We know that just as much as basic sanitation and immunisation was really at the forefront of the most dramatic improvements in public health a century or so ago, and even more recently than that, and some of the more technological advances in the last few decades, genomics is really going to take us to a whole new level at some time in the future. And our systems and our processes and our policies have to keep pace and get ahead of that. And to date, they haven't done that. And earlier this year I was in Scandinavia, indeed I was in Denmark, and I was talking to health officials over there, and I was just amazed at the psyche of people and how much further ahead from a population base and also from a policy decision-making base they are with regards to the clinical application of certain things, with regards to the utilisation of information that's gathered from the individual, how that's used in a de-identified way to assist in making decisions around medicine in the future, the way that information is integrated, not only with regards to medical information, but right across socio-economic demographics. I was at a facility where they had the capacity to basically store and to recall at a whim some 20 million samples. And that's just one part of it. And that, out the back was these amazing cryogenic tanks where they had hundreds of thousands more. And further out the back from there, where they had PhD students sitting down and actually looking at samples, serum samples and such, going back to 1937, testing them for viability, and then also putting them into the system so at some future time they can be used for the benefit of their particular population. And of course, a system where you've got we've got electronic health records that actually talk to each other. And we're only just starting to think about a mechanism that's going to do that. And of course, with regards to opt-out rather than opt-in, that's going to be critical with regards to PECA. All of those sorts of things as well, and the reluctance in the community to trust the policymakers in that area. So we know, and we're starting to understand more each and every day, and you're obviously more at the forefront of this than what I am. The benefit that this will provide to a translation into supporting the patient, supporting the population out there, how we're starting to understand the variances not only in the genome of an individual, but also with regards to the cancers, for example, that we wish to treat, and how those treatments which we thought were ineffective in clinical trials may have been 100% effective in certain patients, but of course because of the variation only appeared to be relatively ineffective, and therefore they were discarded. And the importance that we also should be placing on the fact that not all of our treatments are going to work. We know that with regards to some cancers and our treatments, they don't necessarily provide much benefit, maybe a disbenefit. So understanding what we do before we start on that particular journey is very, very important as well, so we can target and aim our treatments. Of course, we've been involved in this state going back to the 1980s with regards to certain rudimentary types of genetic tests that can assist us in certain ways. An infant's ability to be able to tolerate sugars, for example. What we've done in recent times through Pathology Queensland and our Forensic Science Services Centre with regards to be able to map the differences in Legionella, the differences in diseases and where they've come from, the geographic uniqueness, and so that can help us with regards to our diagnostic tool, and of course making our community aware at large of the challenges that we have, and of course, you know, forearmed is forewarned. But for me, I don't think that we've even caught up to the ethical and social challenges around this. It was brought home to me when I was recently invited, and I'll conclude on this point, Nick, to attend, to get to know your genome conference. Unfortunately, I wasn't able to go there. I was prepared to actually have my genome mapped until I spoke to a geneticist about some of the particular ethical issues that may arise from that. Around, okay, are you aware that once you do this, there could be insurance implications? You may have to actually disclose that if you are asked about that. That could have an implication for your children who may not have necessarily had their insurances all lined up. And I thought, oh, that's very, very interesting. And in places around the world, they've really come to grips with this, and we haven't done that here in this country. So for us to be able to fully realise the benefit of this, we've got to get across that, and we haven't done it. And we've equivocated at a national level, and there is no complete focus and functionality about how we're going to resolve this. As a consequence of that, it actually hardened some early discussions that I'd had with my department about the need to lay down a proper framework of privacy to protect the individual, to make sure that they are able to get the proper benefits that can come from genomics into the future, that those as well in the insurance industry can get certainty about what we believe is proper and ethical and acceptable for them to be involved in or not expect from that particular patient as well, or that individual as well. And we have, as a consequence of that, the department has had some discussions with various agencies that have been involved in at the forefront of genomics to try to actually lay down the framework for a potential legislative response. I would prefer that this be done at a national level, but given that there is some lethargy in that area and that may ultimately hold back our ability to be able to get the full benefit of this, I am very much prepared for us to lay down a framework in Queensland that can give certainty in a privacy sense for the individuals in our community that may benefit from this, but also for those that actually research in this area as well, and also to make sure that the desire of the individual to take advantage of this is not going to be impeded by the unreasonable demands that may come from others, i.e. in the insurance sector, that may be a deterrent. And they're the sorts of very difficult ethical issues that we need to actually discuss, and of course what happens with regards to that information as well. We will continue in Queensland to try to lay down what is a robust environment for clinicians wishing to do research. I think that it's been overly complicated and in many ways has impeded what has been a timely response. Indeed, the technology is getting ahead of ethical approval, and therefore what we need to have is a robustness with regards to an ethical approval framework, which once it's gone through an ethics committee in a particular institution, particular hospital, then it needs to be completely transferable within the state and across the nation's state borders as well. So they're all the things which we're trying to work through at the moment, and we would hope that we can be at the forefront of that, because only by doing that will that actually give you what is the dynamic and fast-moving framework that you need to be able to achieve the real benefits of understanding what genomics can bring in all aspects of clinical care in this state in the future. So thank you very much for the invitation to be here, Nick. I wish you all the very best. Please don't think I'm rude if I have to duck out. I was really keen to be here tonight, and I'm very pleased to spend at least some time with you. Thank you very much, and good luck with your discussions.